memory. After that, so many dynamic meetings you have been able to uh, really take out from your all kind of experiences. Well, I mean, it's years and years ago. Uh, Indian Menopause Society was started, and that too started at my hospital at PD Hinduja Hospital, where Dr. Rabha Vaidya and Dr. Urvashi Jha were the one who was a real force to begin. And then multidisciplinary IMS really started, and it still continues to have it. There are so many chapters have been added, and it's amazing. It's amazing to see what great work is going on. I think I really was surprised and delighted to see that, this meeting is on prescriptions. And what it means is that, of course, we started with HRT in those years, and still it continues that how to help the menopausal women whose estrogen has disappeared, and then this estrogen needs to be replaced, or to learn to cope with it without estrogen. And I think we all have to remain updated if we want to give the best to our women, because these women are really going through rough time. And what you will do for them during this phase will be very important even for future. Because nowadays we all know women live for 90 years. I mean, and maybe this hormone therapy, maybe estrogen replacement may help, or many other things can help. I think today's landscape of menopausal hormonal therapy is really dynamic. It keeps changing, it keeps on updating. Even non-hormonal therapy to menopausal women are also adding so many drugs and so many things to make them comfortable. So I think today's meeting is going to bring lots of lights to newer generation to learn what HRT could do. I think when we say diabetic, obesity, and metabolic diseases, and maybe by giving hormones, it may even help them to even have a better outcome of the disease. I feel the women who are in 90s, their bones are really going to be horrendous, and those maybe who have taken HRT might do well. I'm not the proponent of each things or not, but I think we have to really diligently use whatever is available and how best we can do. And IMS goal is to make this women very, very fruitful journey. And I think with this, I feel that what we are doing and you all are contributing is something very amazing. And let's keep going. Congratulations, all our previous past presidents and everybody. I'm sure his blessings are always there for everybody here. So all the best, and my goes to the another colleague now. Thank you.
Thank you very much, madam. And I now request Anuradha madam to say a few words.
Thank you very much, Dr. Nita Shah, a very favorite, excellent person to me, and Dr. Ragini, the another loving, adoring person, and Shobha, you. You all are very darling to me. And this, as such, in Indian Menopause Society is very close to my heart because they teach each and every doctor nowadays about the menopause and consequences later on, and supplementations and the hormone replacement therapy when and how it is required. But one thing I learned from my mother, the most important thing, that she had her menopause at the age of 44 until last December 29th December she expired at the age of 94. She lived her life 50 years after menopause. She had never taken any HRT, but she was a positive thinker always. And she has 2 fasts in a week, that is intermittent fasting, along with lot of fruits, always encouraging, always mentally active. She was encyclopedia for me, and she retired as a director of education at the age of 60 years. So I just follow my mother, how she lived, what she has gained, and positive thinking is the most important thing, and remain active is the most important thing. And on top of that, we have got very much hikes of emotional ups and downs, the stress situation because of different aspect of the life we are facing, but still making ourselves positive with many moods of swings that we have to control. And the diet, the meditation, the reading, everything is very important. And your this modules of having different prescription for different scenarios, postmenopausal, perimenopausal, are very, very important. And I think we all are going to be benefited, but we have to follow the basic rules of the life. Thank you very much for inviting me.
Yeah, thank you, madam. And I think we are indeed blessed that both of you are here today. And I think it's so very important to touch base with all the seniors, because as I was very thrilled when Asha madam brought in the fact that the IMS was first started at her hospital and under her supervision. And the way Anuradha madam is telling that continuing education is so important, and that is our effort actually. The entire effort is to increase the courage of practicing menopause, specialists to write down the hormonal prescription to older women. Because this is something that is a little new for gynecologists. So with that, Anita ji and Ragini ji will go ahead with the first speaker. And if I can have the CV of Dr. Mahesh, he is waiting here. Mahesh is a very well-known endocrinologist in Bangalore. Currently, this is something that is a little new for gynecologists. So with that, Anita ji and Ragini ji will go ahead with the first speaker. And if what is this? I can have the CV of Dr. Mahesh. He is waiting here. Mahesh is a very well-known endocrinologist in Bangalore. Currently, this is something that is a little new for gynecologists. So with that, Anita ji and Ragini ji will go ahead with the first speaker.
Paresh, what is happening?
I can have the CV of Dr. Mahesh.
Why is it repeating?
He is waiting here. Mahesh is a very well-known. Paresh ji? Hello?
Ma'am,
Audio deliberation of Dr. Mahesh.
Yeah, I think let me just be brief. It is very difficult to introduce such a well-known endocrinologist in a few words, but I will try. He is at Aster CMI Hospital at Bangalore, and he has published very, very widely in the subject. He was awarded the Torrent Young Scholar Award, A.V. Gandhi Award, and the first prize for oral presentation. So from a young age, he has been a very prolific orator, has participated in a lot of clinical trials, Hope 3 and Landmark, has authored the question and answer book and the RSSDI yearbook. He has written a diabetes manual for CMC Vellore, and his experiences, he has qualified from Jipmer Pondicherry, I think, and has been faculty at CMC Vellore and at Columbia Asia, which is now Manipal, and after that he's been in Aster. Do we have one more slide of his, Paresh ji? मैंने 2 स्लाइड बोला था शायद. हेलो परेश जी, एक और स्लाइड है क्या इनका? Okay, so now I invite. Pardon? Okay, I'm not able to hear you. I think it is safe. हाँ ठीक है, okay. We will proceed. Dr. Mahesh, if you can share your screen, is it possible to share your screen? Can you make him the co-host, please? Yeah. over to you. Yeah, thank you.
Slide visible, ma'am?
Yeah, very much. Yeah.
Thank you, ma'am, for the kind introduction. It is indeed an honor to be a part of this meeting, which I hope will transform the life of many endocrinologists to practice in a way which helps postmenopausal women and change in the gynecologist perspective about managing patients with menopause and other comorbidities that are accompanying them now very often. So I will briefly talk about the topic today is fighting the evil trinity of diabetes, obesity, and metabolic syndrome, in specifically with respect to midlife. So this is very relevant today because we have a pandemic that we all faced in the last 5 years. We know about COVID, but post-COVID, we are seeing a huge surge in the metabolic problems, and now we are using the term the syndemic of metabolic diseases, which include the trinity that we just discussed. So despite 3 decades of research efforts, we have not seen any translated meaningful measurable changes in the cardiovascular diseases and the metabolic syndrome or the associated diabetes or obesity. In fact, obesity has increased twofold and diabetes has increased fourfold worldwide. And during the same period in developing nations and say middle income countries, diabetes has increased almost 12 to 17-fold. So that's why we use the term syndemic. And if you look at this map, you can see the red color map, which is predominantly the cities across India. All the cities across India have a prevalence of diabetes that has crossed 10%. And you look at the rural area in certain parts, Kerala, West Bengal, and northern parts, even the rural areas are having diabetes prevalence of more than 10%. So we have a huge surge of diabetes across India, and especially in urban pockets it is crossed 10%, which is really an alarming number, which is like 1 in 10 people you see have diabetes. And this is irrespective of the age above 18 years. It's not the 10% above the age of 50 or 60 that we expect. Usually a surge in metabolic problems, it is happening at a younger age also. The evidence for that is you can look at this graph across 3 cities. You can see here up to 25 years, there is a sort of a flat line where diabetes is predominantly genetic etiology. But beyond 35, we see a surge which goes up to 45 to 50 years when it peaks, and then afterwards it comes down. So you look at this graph in all the 4 cities, you can see the surge happening everywhere. And the peak is sort of in the midlife period between 45 to 55. And that is seen across the cities, and also even in the red line is the rural areas and the blue line is the urban areas. You can see in except in Jharkhand, rest of the areas, even in urban and rural areas of these 4 places, Tamil Nadu, Chandigarh, Maharashtra, you can see a surge in the midlife, even in those people who are living in the rural area. So this graph is just to highlight that the problem is not restricted to urban areas. The problem has moved on to the rural areas also, and diabetes takes off from 25 to 34 years and has peaked in the midlife, maybe around 45 to 55 years, which is the productive period of our life. Again, we can see that the surge is happening more often in the last, say, 5 to 10 years. We have seen a huge surge, which was stable earlier. In the last 20 years, it used to be, having at a rate where the urban-rural divide was well maintained. But last 5 years, we are seeing that the divide is come down. So this is just to show the overall metabolic syndrome parameters, which are the cholesterol, abdominal obesity, hypertension, and dysglycemia. All of them have crossed 100 million, and even more than that, you can see 3 times abdominal obesity, which is one of the key markers of metabolic syndrome. Metabolic syndrome, the origin of metabolic syndrome, we can say starts with the increase in the waist circumference, and followed by which we get the insulin resistance, hypertension, hypercholesterolemia, and then pre-diabetes and diabetes. So there is a sort of moving on from abdominal obesity towards other parameters that we see here starts there. So you can see the number is 351 million, where it is actually the beginning of all the problems that we see in our patients. So the cardiovascular disease in women is one of the most common causes of death worldwide. It used to be considered not very common in the younger age group because before attaining menopause. But unfortunately, it is understudied, under-recognized, under-diagnosed, and under-treatment, and underrepresented also in the clinical trials. So there is something wrong in the way we look at the cardiovascular disease spectrum, which includes the precursors to them, mainly the metabolic syndrome, diabetes, and obesity. So if we deal with obesity, metabolic syndrome, and diabetes very well, we can as well deal with the cardiovascular diseases in our patients. So the time has come to empower women to fight the cardiovascular disease spectrum. So if you look at the risk factors, blood pressure, abnormal lipids, overweight, high glucose level, physical inactivity, and to some extent tobacco use, these are the common risk factors that are common in all. But we also need to know that there are other risk factors which are early menarche, early menopause, and pregnancy-related complications like those who have gestational diabetes, or those who have preeclampsia, eclampsia, or even gestational hypertension. All of them are at increased risk of having cardiovascular disease. So unfortunately, when we take the history, we do not ask the symptoms, the history related to menarche or the menopause or pregnancy-related complications when we look at women. So these have an impact on these risk factors that are already existing. So in the history taking, the first step that we usually do in our clinical practice, time has come to also address the cardiovascular or the metabolic syndrome issue by looking at the menstrual cycles, the onset, and also the sort of menopause age when we look at patients, because we always focus on menopause and bone, and the rest of it is sort of disappeared from our mind. So time has come for us to look at this and include them in our history taking. So once we start documenting, then definitely we will change the way we write our prescription. So we look at this trinity of obesity, diabetes, and metabolic syndrome. Why are we Indians at a peril of this problem? Is because we Indians, even though we have similar BMI, we have a higher fat percentage. You can see in this YY paradox known as the Yagnik-Yudig team. These were doctors in the almost 30 years back. He had a body fat, our Indian doctor had 21%, and the Westerner had Caucasian had 9% at the same BMI. And we are seeing over the last decades of research that Indians have a higher waist circumference, higher fat percentage with the same BMI, and the onset of all the metabolic problems start 10 years younger than the Caucasian population, with a BMI 5 kg per meter square less than the Caucasian population. So that's why obesity is defined by 25 in our Asian population, whereas in the Western population it is defined by 30 kg per meter square. So how do we define the midlife problem? Is we have to understand that healthy aging predominantly looks at robust physical, mental, and social health, which can enhance the quality of life. But midlife represents a critical period where health transition requiring optimal health attention is required, especially in women due to socioeconomic and cultural barriers and physiological needs. Intervention is required to combat the problems that will arise. And if we don't do anything, we are always seeing a surge in the problems during this period. And one such period is the menopausal period, where there is a significant challenge for the physical health and the emotional health, which will affect the quality of life. So we also see that in India, especially the chronic disease spectrum, cancer, cardiovascular disease, diabetes, all start 1 decade earlier compared to the high income countries. So it is around 45 years here compared to say 55 years in the Western population. And now we can see that it is actually coming down to 35 to 40 years instead of 45 years, 10, 15 years ago. And these multiple comorbidities occurring together have resulted in a huge accumulation of chronic conditions during this period, affecting the quality of life. If you look at the old statement by Carl Jung, he always used to say that life really begins at the age of 40. Now we have to say disease also begins at the age of 40, especially the non-communicable diseases. And we need to be healthy if we want to enjoy the fruits of our success. If you look at these two graphs, this looks at 50 years difference, 1950 and 2000. You can see the surge of these two graphs are very similar. The only difference is slight change here. I can say that if you look at this looks like a diabetes graph, but this is productivity and income across decades. To 50 years, still the productivity is always between the age group of 40 to 50, there is a surge. But unfortunately, we are seeing that in the middle income countries, there is a surge of diabetes prevalence in the same age groups. That means, so the productivity is going up, the disease is also going up at the same time. And if we don't tackle this productivity is as good as half of what it is, because we will be spending more time, energy on the tackling disease, the problem. So for women, whenever we look at the spectrum of diabetes, obesity, and metabolic syndrome, we are looking also beyond the conventional risk factors. So always look at pregnancy, gestational diabetes, preeclampsia, PCOS, and menopause as having an impact on the metabolic problems, not just the hormonal related issues. So unless we look at the metabolic problems at the same time, we will not be doing a wholesome care for our patients, especially with PCOS. You can see 40% have metabolic syndrome, and preeclampsia increases the risk of hypertension, diabetes. Gestational diabetes also increases the risk of diabetes. Again, pregnancy, especially delayed pregnancy, where weight gain happens and then it is not lost, also contribute towards increased coagulability. So later the pregnancy, there is more risk of developing the cardiovascular issues. Again, this is just to show there are differences between women and men with respect to the hormonal influences. One thing that I want to say is the mortality rate is similar in patients with diabetes, irrespective of the age. So the women lose the advantage that they have when they don't have metabolic problems with respect to men in the younger age group. Today, we are seeing that women with diabetes do not have any additional advantage that they used to have if they don't have diabetes. So it is very important to understand that if you have a metabolic problem, you lose the advantage that you used to have. Therefore, we need to be more careful in screening them for the conventional problems. Second thing, we also see atypical symptoms in them. So we need to be more aware of abnormal symptoms that are not typical whenever we screen for cardiovascular diseases. Again, the same thing, reproduction and reproductive history has an impact on the cardiovascular disease spectrum. This is just the metabolic syndrome parameters: fasting glucose, low HDL, high triglyceride, higher waist circumference. Especially for Asians, we need to look at 90 for men and 80 for women as the waist circumference, that is the cutoff. This is the standard cutoff for the Caucasian population, whereas waist circumference for Asians is women it is 80 centimeters and men it is 90 centimeters for diagnosis of metabolic syndrome. Here again, you can see the prevalence of metabolic syndrome is quite high in the rural cohort. In the women, again, but we used to always think that it is more in men, but we are seeing that recently the data from 2022 shows that the prevalence of metabolic syndrome has gone up in the rural population also. Again, hypertension, you look at this, women have an increased prevalence of hypertension in the last decade or so. We are seeing higher stroke patients coming with higher hypertension. And unfortunately, because they are underdiagnosed, undertreated, you see the complications often again. Same thing, insulin resistance, BMI, diabetes also is increasing, which increases the cardiovascular risk, and it is increasing predominantly peaking at the midlife between 45 to 55 years. Metabolic syndrome leads to cardiovascular disease, to diabetes, obesity. Again, the most important thing is the harm to the vessels and the organs. And in order to address that, we should not only look at the conventional risk, but also the reproductive specific issues that might have faced the women during their early period and also during the midlife. So again, look at fertility and pregnancy outcomes also, because the metabolic syndrome will affect it, and early recognition is important. There is something called like Q-Risk-3 score, which can be done as an online score. You can do it. It's easy to calculate. Predominantly, it should be done in all patients who come to us in the OPD, especially after the age of 40 years. So you look at this, you will get a good score. Based on that, you can decide the risk and specifically the management. The Q3 risk score, what it does, it shows you the risk of CV event at the end of 10 years. And when we discuss with these patients, we can actually tell them why we are starting a particular medicine at a particular time. Menopause further is associated with increased HDL, increased LDL, decreased HDL, and changes in the waist circumference, body weight, and central adiposity. That is why the additional benefit that the women have before attaining menopause is suddenly disappearing after attaining menopause, increasing metabolic syndrome, diabetes, obesity, and impairment of endothelial dysfunction, including the nitric oxide mediated vasodilation, leads to vascular stiffness and endothelial dysfunction, causing menopause being itself a risk factor for all the metabolic syndrome related issues, cardiovascular disease, and further it can also lead to obstructive sleep apnea. Again, there are a number of issues related to menopausal hormonal therapy. The decision to start this should be individualized and carefully discussed with the patient. Today, we have multiple drugs. I think this data is predominantly from the older estrogens and the older doses that used to be predominantly very high dose and used to cause more problems than solution. But today, we have multiple drugs that are available at a very low dose that can give the minimum benefit that is required instead of causing the problem. So again, the common thing that we do is assess the patient for lifestyle modification, classical treatments, and new treatments depending on the patient to patient and cardiovascular renal risk factors. And we have multiple new drugs that we can specifically target to address these patients and prevent the complications from occurring. First step is always to look at the low carbohydrate diet in promoting weight loss and preventing weight gain, and DASH diet, looking at dietary habits that change with low salt will help in managing our patients. And further, we also look at fat. Fat is considered as a taboo, but it is very important to change the patient from saturated to polyunsaturated and monounsaturated fatty acids. And when we take the plant-based proteins and plant-based fat, actually we help our patients instead of completely restricting the fat. A zero fat is more dangerous than a healthy fat. So always look at low carb, healthy fat, and adequate protein for our patients. And if you do that, lifestyle modification, sleep hygiene, tobacco cessation, alcohol moderation, community engagement, all these will help our patients. But beyond lifestyle, we may require sometimes anti-obesity medication and rarely bariatric surgery. For lifestyle, we look at physical activity and 150 to 300 minutes per day, or 150 to 300 minutes per week, depending on the patient. High quality, hypocaloric nutrition, behavioral therapy, psychologically modify our behavior to understand why weight is increasing and make necessary changes. Unfortunately, this was the old sort of dietary prescription, which is sort of responsible for, according to me, I can say this is a food pyramid that has killed many people and should never have been introduced into the system where the carbohydrate intake was the predominant thing for our consumption. Today we have the complex proteins, complex vitamins and minerals as the complex carbohydrate as the first step. And these cereals are to be taken less compared to the vegetable and fruit. Therefore, the plate recommended by the Indian National Nutrition Program and also the ICMR is looking at predominantly vegetables as our first meal, and look at good protein and healthy fat, and finally come to the complex carbohydrate, wholesome grains. So this is how the table should be, and this is what we should usually practice. Bariatric surgery is recommended for a group that has multiple comorbidities with BMI more than 35, where they are not able to lose weight with a standardized treatment. Further, with lifestyle modification, always weight loss and weight gain is a complex process. We all must have seen in our own life, in our own family members and our patients, that they have lost weight, but they have regained most of it. And it is not easy to maintain it always, though some can really do a difference. But patients with BMI more than 35, it's very difficult for them to lose and sustain. So that's why there are some medicines that help our patients, and current guidelines recommend anybody with BMI more than 27 or BMI with 25 with comorbidities like diabetes, metabolic syndrome can be considered for these drugs if they don't see any change with the first 3 months of lifestyle and that less than 5% weight loss, then we can always consider these drugs. So there are many drugs that are there across the world, but in India today we have the predominantly available is the orlistat, and these three injections, that is liraglutide daily injection, semaglutide once a week injection, and tirzepatide once a week injection, available for us, for our patients, starting at a very low dose. And once they tolerate it, we go to the maximum dose for our patients. So we can choose the patient who are not losing weight with lifestyle modification despite best effort for these drugs. And weight loss is not only lifestyle intervention, because we know that it is sustained in few patients. 10% really sustain it. Rest of them are not able to sustain. But for patients who cannot do lifestyle modification at all, definitely anti-obesity medications play a role. Before ending, I would like to talk about endocrine disruptors. It is a huge problem. We are seeing infertility is shooting up, to a great extent. Unfortunately, it is part and parcel of everything we do. The water that we carry, the food that we carry, the food that we eat, the clothes that we wear, the scent that we use, everything has these endocrine disruptors. The time has come for us to gradually move away from this because they are having predominantly the xenoestrogens, as known as foreign estrogens, but their biological effects go beyond estrogen into the spectrum of autoimmunity, cardiovascular disease, diabetes, prediabetes, and even cancer and infertility. Some of the molecules are the BPA, dioxin, hexazine, phthalates. Phthalates are very common in almost everything that we use. It leads to PCOS, thyroid disorder, breast cancer, mood disorder, autism, diabetes, cardiovascular disease. Time has come that everything that you use, please check the label. If it has any of these, kindly reduce them as much as possible. This is not only for patients, for doctors also. We as doctors, if we don't take care of ourselves, we cannot expect others to come for us. So please look at endocrine disruptors as one of the things in our day-to-day history taking. Always look at a patient, what they use, how they walk, or what people predominantly consume stored water in a plastic is something that will consume these endocrine disruptors on a daily basis. So we need to gradually move away from plastic storage of food towards olden days that we used to use the steel and glass to reduce the impact of these EDCs. Towards the end, I would like to say that PCOS and other metabolic problems like fatty liver should be considered along with the other conventional risk factors like hypertension, obesity, related issues, dyslipidemia, glucose level. But we should always look at patients whenever we look at planning for menopause, look at the atherosclerotic cardiovascular disease risk factors along with the history of their pregnancy, hypertension, early onset of menarche or early onset of menopause as problem. So in the end, probably we need a cardiometabolic clinic where everybody is involved, from a nutritionist, dietitian, specialist, focusing on education and counseling of the patient along with diet, prescription, medicine. Then only we will be able to address these problems that we are facing in the midlife. We need a way ahead, and I'm sure that in the near future, the AI, artificial intelligence, will help us gather data very well in such a way that the data will help us talk to the patient in a better way. With this, I thank you all and will be happy to take any questions. So final slide to show that this may be an AI model of a new clinic which will be able to look at everything, including the blood test, the genetics, the indicators, the epigenetics, medical record, history, and their previous medicine intake, and also maybe their nutrition and EDCs also in the end. And finally, we may be able to give a better prescription for our patients in the near future. And I'm sure next 5 years we will see a huge change in the way we practice our medicine. Thank you.
Yeah, if you could please stop sharing, sir. Yeah, wonderful. Actually, from such a young mind, so much of knowledge has come forth. Thank you, Dr. Mahesh, for being here. Since I have been practicing many years in Bangalore, I feel that you are much younger than me, but I can see that you already have a lot of clinical experience with you. Yes, Dr. Ragini.
Yeah, Dr. Mahesh, can you throw some light on these new drugs which was being discussed in a lot for this all obesity reduction, diabetes control, all this semaglutide and the new drug Mounjaro?
Yeah. So today we have 2 new drugs available in the Indian market. It is available in the Western population for almost 5 to 7 years now. And the first drug that came was known as Ozempic, that is the semaglutide. So these are available in India from 0.25 mg to 2.4 mg. So whom do we really ideally start this drug? The most often prescription that we usually use semaglutide is patients with additional risk factors. Just obesity should not be the reason to start them, because what happens is that the psychological impact, we have seen that these patients take for a particular reason of weight loss, and once they lose weight they stop the medicine and they regain most of it in the next 1 or 2 years. So it is very important to screen the patient for metabolic problems, tell them to follow lifestyle for at least 3 months, and at the end of 3 months, if you see that despite their effort they are not seeing any change in their weight, which we expect around 4%. So if somebody is 100 kg, with lifestyle they should at least lose 4 kg. If they don't lose even 4 kg despite best life, that means that the energy metabolics in the body has changed. So they need additional molecules like GLP-1, which really benefit the patients. And we start with a lower dose 0.25 first 4 weeks, then give 0.5 next 4 weeks. Then depending on the tolerating the medicine, will increase to 1.7 and 2.4 over 6 months, and continued for at least 6 months more to see the maximum benefit. What we have seen is that in the studies that up to 14 months is what you get the maximum benefit. Beyond 14 months, nobody loses additional weight. So I would always recommend patients to take for the, if they are tolerating, whatever maximum dose for 14 months, and then discuss with the doctor how much lifestyle modification they can maintain, and decide to reduce the drug to the dose that is can be tolerated without gaining much weight. So that is what I recommend for patients who are obesity. For diabetes, we would like to continue the drug because it gives glycemic control, cardiovascular benefit. It is like a drug. It is not sort of what you can say a weight loss molecule that you stop. So for diabetes patients, we predominantly require them to continue for a longer period of time at a dose that is beneficial. I can give you one example. Since 1 year, one patient used to come. He was 125 kgs, and despite taking insulin of 80 units, his HbA1c was 9.5. I started him on the Monjaro, that is tirzepatide, and within 3 months he lost 15 kgs, and now he's off insulin. He's taking the other medicines.
My question
That is great.
can we,
So,
can we give both semaglutide and the Mounjaro to
No,
one
no,
patient?
simply one.
See, if we are, I am here talking about not only a patient who is obese, a midlife woman who has a obesity along with the diabetes. Maybe she is control on some OHA and everything, but she is obese. She is not able to lose weight.
They can,
She start the semaglutide and continue whole life to control the diabetes also.
yes. Either one. You start either one and continue. Long period, you
neither of
reduce
them,
the other
neither of
medicines.
them, not both of them. That
No,
was
no,
the
Mounjaro
question.
has no effect on diabetes.
It has.
Direct effect like semaglutide, or it's
Yes,
a weight
similar.
reduction.
Weight reduction and glucose control both are very good for
Is
glycemic
there
control.
any
The glycemic
Ozempic is
control
what?
is similar.
Ozempic is what? Ozempic is
Ozempic
semaglutide?
is semaglutide.
Semaglutide. So how to kind of select between the two? Maybe what is
Yeah,
some
for
of the...
glycemic control, both are very similar in their effect.
Okay.
There is like 0.2 difference. For weight loss, Monjaro is more beneficial. So for example, I prefer Monjaro for patients who are weight is say 130, 150, because
Okay.
they can lose 15-20% weight. But for somebody who is having diabetes, weight is around 80 kgs, I personally prefer the semaglutide, because there are other benefits that have been documented, which are not yet like cardiovascular benefits.
Okay, because
Cardiovascular
For
outcomes are much
with
better.
semaglutide. Yeah, with
Yes.
semaglutide, cardiovascular benefits are there.
Mounjaro
Monjaro doesn't
is
have
not
these
there.
kind of benefits.
With Mounjaro, it is not there.
Monjaro, it is there, but it is not
As
additional beyond the other drugs.
one thing which will help us to understand would be how each of them acts, because there are some 2 questions, 3 questions in the box which we will take after you answer this. Yes.
Semaglutide acts on the GLP-1, increases
What
just
is
the GLP-1 in the body.
What is
GLP-1 is a glucagon-like peptide that is released in the small intestine, the distal part of small
Okay.
intestine, especially the jejunum and the ileum. So it is increased only when food reaches the intestine or normally. So normally when we eat food and we have after say 20 minutes or so when the food reaches intestine, GLP-1 is increased, but it is broken down very fast by an enzyme called DPP-4 within 20 minutes. So it is not there in our body throughout the day. So what happens is the GLP-1 that we are giving as an injection or a tablet stays in the body throughout the day. So what does GLP-1 do? GLP-1 has two effects. One is on the brain and another is on the gut and the pancreas. On the brain, it suppresses the appetite.
Appetite.
It makes you feel that I am full, I don't
You're
want to
full,
eat. It's
full.
like a switch,
Satiety.
clear switch. It's like brain has a switch. If you press the button, don't eat, the GLP-1 will go and touch that button and you don't eat. Don't, even if you have one mug of coffee that you like forever, you keep it in front of you. If you have taken GLP-1 and the working, you cannot take more than 1/3 of it. You will not, you will just throw it. No matter what happens, the switch is so strong in the brain. It's like when you don't want something, you not do it. Like that, the switch will work and you will not eat at all. And you will eat, predominantly the intake comes down by 30 to 40%. The second effect it has is on the intestine where it delays the gastric emptying. So you feel full early. Don't feel that you after eating, say one chapati, you feel like, okay, I'm full, my stomach is full because the food is not moving normally that it should do. So there's a delayed gastric emptying, so you feel full and you don't feel like eating. The third thing it does is increases the secretion of insulin and decreases the glucagon. So it has an impact on the liver in terms of
Fine.
reducing
Okay.
fatty liver.
Mm.
Terzepatide has additional effect. It is also known as GIP, the glucose insulinotropic polypeptide, which works on the fat. It has improves the fat metabolism, the peripheral fat and the abdominal fat that is there. It acts on that and reduces the insulin resistance there, and fat metabolism improves. So that's why it has an additional effect compared to the GLP-1 that is there in semaglutide, whereas terzepatide has both GLP and GIP effect.
Dr. Mahesh, can it be given to a person who has a gastric bypass also? Because this is the
Not
lightning discussion nowadays.
I would not give it for somebody with gastric bypass, but for sleeve gastrectomy, yes.
Why?
Acha. Mm.
Gastric bypass, the intestine is already cut. It's very small,
Correct.
and the chances of side effects will be more. We have to diarrhea, nausea, vomiting. We would be very cautious in somebody who has had a gastric bypass to give this.
Even with the injections?
Yes, yes. I would probably discuss with the patient if they have gained too much weight, then tell them that we have to take, we can sometimes give half of the lowest dose and try, but that would be be very cautious to give it for a patient who had a Roux-en-Y gastric bypass. If it is a mini gastric bypass where they have just joined the intestine and the stomach, which is not the intestine, then we can use it. There are like 4 procedures. I would probably give it only for these 2 procedures, that is sleeve gastrectomy and mini gastric bypass. In them, I will use, but not the others.
Correct. Mm. So to quickly take 1 or 2 questions so that we have room for the next speaker also. Any association with thyroid cancers, dosage?
Yes, medullary thyroid cancer is something that people need to be cautious. Any family history of thyroid cancer, we avoid this. If there is no family
Both
history,
of
we
them.
usually look
Monjaro
for
also.
both. We look for any thyroid nodule, and if we look suspicious, we get an ultrasound FNAC done. Otherwise, usually it is not a major thing to worry.
One thing was, what are the tests required to be done by gynec before sending the patient? No, for before starting Ozempic or Monjaro, do we need to assess the patient for something like that? Yeah.
So always we want to look at the metabolic problems that the patient has and thyroid dysfunction. So look at the glucose level, lipids, and thyroid function and kidney function before starting the drug.
Yeah.
Because the side effects are vomiting, nausea, and electrolyte disturbances. So if they have hypertensive patients, especially on thiazide diuretics, please do the electrolytes before we see the patient.
Thank you immensely,
I would
Dr.
like
Mahesh.
to
And I
ask.
think, yes, ma'am.
Yes. What about the blindness? Only yesterday, my daughter was mentioning that some studies have come that it caused blindness.
Yeah.
So I'm very much worried for it.
Yeah, patients with diabetes and retinopathy have a risk of worsening of the retinopathy when there is a rapid control of glucose. It has been almost seen with all the drugs. Like even we saw it with pioglitazone also, where the glycemic control achieved very fast. They develop macular edema. So that's why we always screen these patients for retinopathy. If they have proliferative diabetic retinopathy, macular edema, or moderate to severe non-proliferative diabetic retinopathy, we usually avoid this.
Means if a person is not already have a problem in the eye, a normal
Then
person have no chance of having a blindness, no?
no,
Okay.
till now not documented. It has been seen
No, we
only
have
in
to
patients
screen,
with
no?
diabetes.
Annual screening has to be done for all diabetics, the
Yeah.
eye screening. Yeah.
Yeah.
There is one question, which is safer, tirzepatide or semaglutide?
Both are safe. The one thing difference is most common side effect is there is a small difference that even though the studies have shown both are similar, diarrhea is slightly more common with tirzepatide compared to semaglutide, and vomiting or nausea is slightly more common with semaglutide compared to tirzepatide. Both are good, safe in the patient, right patient. Choose the right patient, you will see the best results.
Can a gynecologist prescribe this?
Yeah, first time maybe one or two patients you discuss with the so that you are very. The problem is that what I have seen is that there is something called as the first dose side effect. When you not usually don't use a drug, you start a drug. First patients comes with side effect, then you will feel that oh, what happened? I start this drug and patient develops side effect. So always in consultation you can start, and then you can. I would suggest that you do the continuation or increasing escalation phase under your supervision.
What is
before
DP4 inhibitor?
Sorry, ma'am.
DP4 inhibitors.
DPP4 inhibitors are those drugs that block the DPP4 enzyme, which usually metabolizes the normal GLP-1 produced in the body. So when you block that enzyme,
drug?
Drugs are vildagliptin, sitagliptin, linagliptin,
they are
saxagliptin.
being
These
commonly used. They are being commonly
yes, they are used for diabetes. It doesn't cause weight loss.
So you will not give these two drugs together?
No.
Semaglutide and
So obese women, you will prefer these, no? Semaglutide and obese women with diabetes, right?
Anybody with
Only
BMI more
women
than
maybe
30.
go for DPP4. So I just wanted Dr. Mahesh to give one message to everyone. I think Ragini will and Anita madam will agree with me because you said that for the first dose, you consult an endocrine, but our belief always has been that we should have a multi-pronged approach and multidisciplinary care. By the time the woman starts requiring these drugs, a lot of independent risk factors for cardiovascular disease would have built up, right? So to have a very holistic approach, and we have to look at other things. We have to look at bone protection. We have to look at MHD. We have to look at cancer prevention. When there is so much involved, I think the gynecologist should not take the onus alone. I think it is important that we make it multidisciplinary, and that is the real strength of a menopause care and menopause clinic. It gives best results. I think Ragini, isn't that? Yeah. So with that, we thank Dr. Mahesh immensely, and we will go on to the next talk. Our very own Dr. Mahesh, if you are having patients, just keep logged on the side and see in the chat box. Anybody is asking you anything, please respond. Because I think people are very keen to learn from you. Thank you so much.
Thank you.
And we go on to our own Dr. Hepzibah. Can I have her CV? Yeah. So I'm very glad that Dr. Hepzibah is speaking today. She has been a friend for many years, and I think she's a very well-known figure, a brilliant orator in IMS circles. Can I have her CV, please? Dr. Ragini, आप introduce करेंगे कि मैं करूँ?
No, I will do it. Gladly, I will do.
Please do it. Can we have?
The first thing, I don't think everybody knows Dr. Hepzibah in our IMS.
कोई introduction ही नहीं चाहिए.
And we all know she's from Chennai. And one thing maybe few people don't know, when I see Dr. Hepzibah, I always think only one thing. How anybody is such a good academician and such a good mouth organ, person also. First time I heard, I thought, wow, one can have a combination of everything if you want. So, Dr. Hepsi, Hepsiba, we will welcome you. I'm not going to speak. We want to listen you.
Yes, thank you so much for
सीवी नहीं आया क्या डॉक्टर
अरे छोड़ो यार,
परेश?
क्या सीवी मैडम आ गई है,
ठीक है,
मैडम
चलो।
देख लेंगे।
ठीक है, शेयर कर लीजिए ना, आप शेयर कर लीजिए।
कौन करेगा?
I think her we can.
No,
She only has to share her slides. She's made the co-host.
can I
Yeah.
share my slides?
Paresh, make her co-host ना? हाँ, हो गया।
You are able to see my slides?
Yes, yes.
Okay. Yeah. At the
Screen.
outset, am I audible?
Yes,
Yeah,
yes.
at the outset, I respected Anita Ji, Madam, Ragini, Dr. Shobha Gudi, and our senior Asha Kaparia Madam and Anuradha Madam. It's a privilege to say few words from my side. I don't know whether I'm going to do it justice, but anyway, I thank for the opportunity given to me. And when this was given, few questions came to my mind. What are the contributing factors in peri and postmenopausal period for metabolic syndrome? What are the preventive strategy? What is the role of obesity reducing diet, bariatric surgery? What is the role of MHD in metabolic syndrome? So as all this we know, the elderly women will outnumber men and life expectancy, as Anuradha Madam was rightly said, we are on the increasing trend. And life expectancy, it will go till nearly 77 in 2050. And by 2050, the India's senior citizen population may cross 300 million. So the junior doctors should know about the geriatric problems. So 1 in every 2 women will experience 30 years of postmenopausal period. 1/3 of their life is spent in postmenopausal period. And we all know all the complications. It's a public health problem. But to enjoy good health, lifestyle changes should start at midlife or still earlier also. So coming to the metabolic syndrome, the components, everyone knows about it: high blood pressure, blood sugar, triglycerides high, low HDL, abdominal obesity, and they are prone for stroke, heart disease, and requires 3 or more of this criteria. So this has been already mentioned about this by our previous speaker, and all this he has enlisted. And actually, pregnancy is a window of screening. If everything goes all right, the later life will be good. But among various risk factors he enlisted, the obesity contributes the major risk factor for metabolic syndrome. And when we come to menopause and metabolic syndrome, it is actually the menopause is associated with all the components of metabolic syndrome, like visceral adipose tissue accumulation, atherogenic dyslipidemia, insulin resistant, and increased BP. And according to the SWAN study, the incidence of metabolic syndrome increased gradually between 6 years before final menopause period and 6 years after final menopause period, regardless of the age and other known CVD risks. So the menopause itself can be a risk factor. Approximately 13.7% of the women in SWAN cohort had new cases of metabolic syndrome at the time of final menopause period. So the metabolic syndrome is a storm. You don't see it is coming. It is also like osteoporosis, silent on the onset, but it has got a devastating impact. So there is a weight gain in midlife. See, the major contributing factor is the obesity, we have known. And the weight gain starts at the midlife. So that was, people were debating for a long time, whether it is due to the aging or it is due to the changes in the menopause. In midlife, there is a change in body composition and fat redistribution. These are all primarily due to ovarian aging. Okay, so on average, women weight gain is 5.5 per year, especially during menopausal transition, irrespective of the race and ethnicity. It is as a result of physiological changes of aging and lifestyle changes, and aging decreases the resting metabolic rate and total energy expenditure. We may not feel like this. So decrease physical activity and metabolic rate decreases, that increases the weight gain. And other contributing factors also is there: sleep disturbance, mood changes, obesity, psychological activity, obesity associated with urbanization, inactivity, family history of obesity. There is an increasing evidence disruption of circadian rhythm, timing of food intake. See, all these IT people have a regular timing as seen with the shift work and sleep deprivation also contribute to weight gain.
Okay.
So how this estrogen is important, and estrogen, and when we look at it during pre-menopausal period, lipid deposition in glutofemoral adipocytes is facilitated by lipoprotein lipase via estrogen action to assure adequate energy. This activity in glutofemoral adiposity is higher than in the abdominal adiposity. But what happens in the midlife? There is a body fat redistribution, and it goes to abdominal visceral fat deposit. There is a lipoprotein deposity is reduced.
डॉक्टर पुष्पा म्यूट कर लो अपने को, आपकी सारी बैक से आवाज आ रही है. पुष्पा बिश्नोई.
So, and unfavorable changes in body weight and increase in the central body distribution. There is a redistribution, so it becomes a android shape. In postmenopausal women, femoral adipose tissue shows low lipoprotein lipase activity, and abdominal there is an increasing visceral fat deposition and higher lipolytic activity. These changes are very much seen even during menopausal transition and menopause. So there are redistribution and transition from gynecoid to android pattern and increase the total body weight. So as already told by Spencer, every cause produces more than one effect. It's similarly, and impact of endocrine perturbation is expressed in visceral than in the subcutaneous tissue, and which has got more of cortisol, androgen receptors, and higher than the other level. And it acts as an endocrine organ and secretes adipokines and other substances that are closely associated with metabolic disease like insulin resistance, type 2 diabetes. And this is the mechanism. When there is an estrogen is reduced in menopause, leads to loss of subcutaneous tissue, visceral adiposity, and the bioavailability of testosterone increases, but estradiol is decreased, increase free androgen as well as decreased sex hormone binding globulin, decreased lipoprotein lipase activity. Cortisol also increased. FSH might stimulate fat redistribution and contribute pro-inflammatory milieu, increased visceral obesity, and altered plasma lipid. This is the mechanism by which everything happens. So when there is a midline transition, weight gain, visceral obesity, insulin resistance also decreases, and this is the final thing. So androgen predomination, central obesity, this causes increased insulin resistance, free fatty acid, decreased adiponectin, apoprotein secretion, and increased triglycerides. Increased hepatic lipase reduces the HCl, leading on to metabolic syndrome, and sometimes they increase the risk of cardiovascular disease also. This is the certain principle we have to undertake when we treat peri and postmenopausal women with metabolic syndrome. The best thing is we have to identify, and the risk assessment should be there. Lifestyle modification is the first line and cornerstone. And of course, there is a specific treatment, targeted treatment for hypertension, dyslipidemia, diabetes, and antiplatelet therapy. Also, we have to look into it. And of course, weight loss by either a pharmacotherapy or bariatric surgery. And when they have a specific complaints regarding menopause, we should take care of it. And they need to have a long-term follow-up. And it should be a team-based care. All this we were discussing about by the previous speaker. So everyone has to take part. Each has got a important role. So midlife screening and examination is a window of opportunity to prevent health disease. And screening, whom to screen? Whom to screen? All midlife at routine visit. See, we are very often gynecologists are the first contact person with the central obesity and menopausal transition. So all midlife should be, women should be screened. What to screen? Someone was asking what test we have to do. Be the basic physical examination, waist circumference, BP, and fasting glucose, hemoglobin A1C, ALT if you are suspecting a non-alcoholic fetal liver disease, and urine albumin if there is a diabetes already, and microalbumin. Frequency at baseline and annually or earlier if abnormality set in. This is very, very important. This is in our hand. Okay. So, this is the weight ratio, which gives a risk of metabolic. BMI is not a powerful indicator. It is it doesn't give indication about the central or abdominal obesity. So the abdominal circumference and waist hip ratio is an indicator of a visceral fat disease, and it is a stronger anthropometric correlate with the quality of visceral adipose tissue. And of course, we have a lot of newer gadgets are the CT, MRI, which can be done. So the first thing is to prevent strategy to prevent weight excess is the physical activity. It prevents achieve weight loss. The physical activity, loss of muscle mass with increasing age, it prevents against bone loss also. This is the thing which we recommend. Minimum actually 30 minutes per day for 5 days in a week, or 15 minutes in the morning and 15 minutes in the evening. Either you walk, jog, or run, and preferable target is the 300 minutes per week, 30 minutes, 60 minutes per day, and 30 in the morning, 30 in the evening, and vigorous intensity 150 minutes. This is the preferred thing. At least minimum requirement, we should do it. And of course, muscle strengthening exercise. We all should insist them for peri and postmenopausal muscle strengthening exercise, like frequency 2 to 3 days per week, free hand resistance, push-up, sits-up, squats or weight training, and flexibility exercise, stretching and yoga, lifestyle modification. We can counsel them to take stairs, and cycling is a good exercise. So that coming to the diet, there is calorie restriction. I think he has also mentioned about all these things. Diet and addiction to exercise, weight loss will be more than 5%, and it reduces the risk of metabolic syndrome. And preferably the options are low carbohydrate diet, low fat. A Mediterranean diet is almost similar to our Indian diet. In addition, we need to have a vitamin D and calcium rich food. There was a study which the traditional healthy diet like seafood, seaweeds, grains, dairy products will reduce the metabolic syndrome. So apart from low carbohydrate diet, it's better to prefer 30% preferably and reduce the calorie intake. Saturated fat should be less than 10. And we have to prefer polyunsaturated fat at less than 10%, and monosaturated fatty acid. These are all the diet which can have a unsaturated fatty acid and polyunsaturated. And sugars should be refined sugar, less than 10% of daily calories. Salt, less than 5 grams per day. Cholesterol, increasing diet, it should be 300 milligrams. So we should avoid all this creamy, sugary food, and lot of pulses, fresh fruit, cereals, we can be that. All this, I think he has also mentioned about it. In nutshell, We have to reduce salt, sugar, saturated fat, avoid sedentary lifestyle, smoking, alcohol. To stop stress, we have to avoid. So weight gain is based on calorie intake and physical activity. And yoga, certain other things also we can do to reduce the weight gain. Yoga improves your adiponectin level, serum lipids, and obese. It is very useful for that. Increased yoga experience predicts lower body mass index and reduced medication use. That has been proved in one of the journals. But long-term practice is linearly associated with decrease in BMI. Several studies, middle-age and elderly, they have concluded there is an improved metabolic parameters. Other conventional things also people have done. Alternative therapy, acupuncture, believed to induce weight loss via its regulatory effects on nerve and endocrine function. It has been proved in one of the journals. And to consistently, it should be the weight gain. Once they lose, they regain also. They should practice consistently. That is about. And this has been explained by our previous speaker in depth on how this metformin, GLP and all will reduce the bariatric surgery. Also, he has mentioned about it. I'm not going to go in detail. In addition, we should insist our perimenopause and postmenopausal people in nutrition, supplementation such as either rich food and vitamin D, omega-3 fatty acids and phytochemicals, probiotic. We have lots about probiotic they're talking. So coming to menopause, specific consideration, MHD is not for everyone. It's only for symptomatic women. Estrogen therapy remains the gold standard for the menopausal vasomotor symptoms, but we should start before 60 years or within 10 years of menopause. The smallest effective dose for the shortest duration. The major contraindication will be established CVD and a breast cancer and a thromboembolic disease. So when we look at it, whether we can give hormone therapy in metabolic syndrome, so we have to have some evidence-based medicine. There's a lot of publications regarding effect of MHD and metabolic syndromes. The hormone replacement therapy provided with the selected progesterone does not antagonize estrogen action and may improve fat mass and redistribution, dyslipidemia, and insulin sensitivity in postmenopausal women. We have to choose the mode of the therapy and the combination. The Danish osteoporosis prevention study says, and it is a randomized control study, it showed that they gained less fat than the control. The weight reduction is there. So now all this study, her study, PEPI study, WHO study, produced a reduction in LDL, increase in HDL, increase in triglyceride. In SMART study, the LDL is reduced by 9% at 12 months and 7% at 24 months, and increase in HDL by 5% at 12 months and 6%. I don't know why it is decreased after 24 months. So there's a lot of study support. We can give menopausal hormone therapy, but there are the recommendation. It should be given with a caution because it is associated with high risk of cardiovascular events. So when we start giving this, we should keep it in mind. So transdermal estrogen and micronized progesterone, because micronized progesterone is natural and it has got less inflammatory changes, and it is very neutral with coagulation and insulin sensitivity for menopausal women. So it is ideal to choose the micronized progesterone. Why we are choosing transdermal? Because it is efficacy and safety also is there, suggests that food can affect all. The advantage is the less effect on liver, no first pass, both total cholesterol and LDL will reduce, increase HDL and reduce triglyceride, no incidence of VTA. So the newer modalities are there, so we can safely give transdermal. But the precautions to be taken while prescribing MHT will be, so as I already mentioned, it should begin within 10 years of menopause and less than 60 years. Low dose and progesterone we should choose appropriately. Of course, the route of administration will be transdermal. The progesterone, the side effect profile, various progesterone may play a clinical role in selecting it. See, the newer progesterone like droxiprone may be good consideration in hypertensive women. Neutral progesterone like micronized progesterone and D8 are preferred because they are neutral to atherogenic effect and the inflammatory changes. So we have to select. So before giving prescription, we need to have a thorough evaluation of each patient, screening test and annual follow-up we should discuss with them. The dose and duration should be individualized. Risk-benefit assessment should be carried out. It should be an informed choice. Full gynec assessment is mandatory prior to starting MHT and a regular intervals thereafter. Self-breast examination, we are supposed to advise them, and clinical breast examination at least annually. A mammogram, whenever available, should be carried out 1 to 3 yearly. So these are all the things we should do before starting an MHT. So the patches are available, 17 beta estradiol. It releases 50 microgram for 24 hours. The gel is also there. With each squeeze, it delivers 1.25 grams of gel, which contains 0.7 milligrams of estradiol. So before that, they have to wash and all. We should give the instruction properly. Gently, we have to rub the gel over large area of clean, dry skin, and especially on the lower body or arms, and they have to wait for 5 minutes and to dry before getting dressed up. We shouldn't wash the area for at least 1 hour. And the spray is available. Sorry for the wrong heading. The inner forearm, if 2 or 3 sprays are prescribed, it is to be applied side by side, and it should be allowed to dry for approximately 2 minutes and should not be washed for 60 minutes. One spray once daily, it releases 1.53 milligrams. So there are, the preparation is available. The progesterone we have to choose depending upon whether you are going to give a micronized progesterone or the dihydrogesterone. So the follow-up of following an MHT is very, very essential. After 3 months, we have to ask them to come. After a month itself, we have to come, whether there is a complaints about the hormones. And after 3 months, we have to check for side effects, BP, weight gain, and then annually, cervical smear once in 3 years, self-examination, breast examination monthly, and clinical breast examination at least annually, mammogram when it is available, PV if necessary, and whether to stop for symptoms, whether it can be stopped abruptly or gradually. So we were talking mostly this metabolic syndrome is due to all the changes, and especially the abdominal obesity is the main culprit because there is a redistribution due to estrogen lack. So we have to tell them to invest in lifestyle changes as a healthy diet, physical activity, screening. When they come to us, we have to screen. It's our duty to screen so that they can have a brighter future. And of course, the prevention is the key. That is why we have to target at the midlife people. And whenever any patient comes for some other this thing also, we have to screen them for all these things. Simple weight skip ratio is an indicator. If necessary, we can do the other things also. Targeted pharmacotherapy is another one. So look at this lady is 98 years, Padma Shri holder. She is a yoga grandma. She is able to do yoga. So that is the thing. So MHT in metabolic syndrome, only for symptomatic women. So we should choose a right age, right type of MHT, right dose, and right route. So life is a marathon, not a sprint. Pace yourself accordingly. So we are targeting about the midlife life. Indians attain menopause earlier And Indian phenotype has increased insulin resistance and greater abdominal obesity. Hence, a woman in midlife should pace the lifestyle accordingly for an optimal BMI. Once you committed yourself to do something, pace yourself, pace wins the race. Pacing to control weight gain in midlife is to win health problems when they reach menopause, and it leads to smooth sailing. Pace wins the race. So to conclude, we have to be fit at 40, strong at 60, independent at 80. Thank you for patient listening.
Thank you, Hepzibah, for that wonderful, realistic presentation. Excellent presentation. Thank you very much. For paucity of time, I'm sorry, I'll just go ahead and share my screen. And the questions we can take at the end of both presentations. I'm sorry that we cannot have time for interaction because we have a physiotherapist also waiting. So I hope everyone can see my screen. Ragini ji, screen दिख रहा है मेरा?
जी देख रहे हैं चलिए.
जी. So MHT to support menopausal care in women with obesity, DM and MS, I'm very fortunate that Dr. Hepzibah has already covered it in so many ways. This will be just a reiteration and a bit of revision and also an attempt to increase your conviction that you can prescribe MHT to such high-risk patients also, if it is necessary. So as first thing, this is a case. Let me have the case. 55-year-old obese diabetic with a history of PCOS in the past. Now she seeks, sorry for the spelling mistake there. She seeks care for severe vasomotor symptoms. So sometimes actually practitioners feel that women who are obese will not suffer from VMS. That is not true. They can also suffer estrogen deficiency. It's not that they're always estrogen replete and the peripheral conversion may not be happening as much as we think. So the severe VMS 1 year after the final menstrual period. So she seeks care and she is already under treatment for diabetes and she is already trying something for her obesity. So first thing which we need to do for her is to assess the cardiovascular risk factors. In addition to everything else, our primary aim will be to assess, because as the first speaker also said, that this is the commonest cause of mortality for women like this, okay? So women who have established cardiovascular disease are poor risk candidates for any kind of menopausal hormone therapy, and we have to look for alternative therapies in them. Women who are high risk patients for cardiovascular disease also need to be screened out. Who are these women? Who have non-coronary atherosclerotic arterial disease. For example, if they are having atherosclerotic, mesenteric angina, if they are having atherosclerotic, on a CT angio without having any diagnosis of cardiovascular disease. If they are having atherosclerosis in the cerebral artery, something like that. So if they are having these kind of atherosclerotic disease, we should be able to know. That is why it is important to have some kind of consultation preliminary to pick up this non-coronary atherosclerotic arterial disease. Then women who are having diabetes, as is our woman, even if she doesn't have established cardiovascular disease, she is high risk for cardiovascular disease. Chronic kidney disease, hypertension, dyslipidemia, lifestyle factors, those who are sedentary, inadequate exercise, most people will fall into this lifestyle factors. Most women are at high risk for CVD because of their lifestyle factors. And then there are a subgroup where inflammatory markers are raised. For paucity of time, we'll not go into the details of this. But why I wanted to put all these high-risk patients are that these high-risk patients should be the same precautions should be taken as established cardiovascular disease as far as prescription of hormones is concerned for them. So we need to be extremely sure that the diabetes is well under control, hypertension is well under control, lipids are behaving themselves, and lifestyle factor, full rectification has been done. So what are the roles of a gynecologist for prescribing MHT? So we need to address the underlying drivers of obesity and metabolic syndrome through lifestyle modification, which Hepzibah brought out very beautifully. And what I want to say is the whole prescription should be in place, not just MHT. The statins should be in place, antihypertensive, anti-diabetic drugs, any other drugs that she is on. We must keep in mind that obesity is directly a risk factor for cancer of all kinds, and diabetes is directly a risk factor for endometrial cancer. So prevention of cancer should be kept in mind at all times, and necessary steps should be taken. And of course, osteoporosis prevention also should be paramount in our minds. And then we come to the MHT. That should be dictated by the situation, how much symptoms are there and what are we looking at. So the detail of LSM, the lifestyle modification, let me not go into it. Only the highlighted facts are that augmented weight loss with exercise and diet will actually, bring about changes in absolutely all the parameters of control in these women. So we need to push them towards sustainable exercise routine. Again, I'll not go into the detail. Diet planning, which has already been told, the different types of diet, the Mediterranean diet, fruit, vegetable, nuts, whole grains, olive oil, low fat diet, DASH diet, restricted sodium and high dairy intake diet, that is the DASH diet, and low glycemic index diet, and high fiber diet. And then there is also that intermittent fasting, which people are doing with success. If your GI system tolerates it, you can go for it. It is beneficial. It is beneficial for obesity, diabetes also. And smoking, alcohol, all these should be corrected. And mental health also should be positive. So engaging in another career option, because unless they are positive in their mental frame, they will not be able to follow the lifestyle modification. So they need to have a highly positive outlook and have restful sleep of 8 hours. So these are the things, basic things, which we go on telling them, and we also follow ourselves in our everyday life. Now, the independent modifiable risk factors should be in. That's why I said that we need multidisciplinary approach. Everything, the hypertension or type 2 DM or hypercholesterolemia, triglyceridemia should be under perfect control. ACE inhibitors, calcium channel blockers, ARB agents are very good for hypertension, but thiazide diuretics are less suitable. They can affect glycemic control in these women who are having obesity and diabetes, and the lipid profile also. So be careful about that and speak to the physician and try to get them off the thiazide diuretics. It's not good for our women. Role of MHT. There's good evidence to support that MHT is safe and beneficial, and the benefit will outweigh the risk when they are healthy, symptomatic women that we know. We prescribe for VMS, for GUSM and sexual dysfunction within 10 years of menopause and younger than 60 years. Recent evidence says that we can continue beyond this in well-controlled situations. Well, that is a different story. The contraindications are very few: breast cancer, active coronary heart disease, previous thromboembolism, stroke, active liver disease. Intact uterus, add progesterone, that everybody knows. Vaginal atrophy, low dose vaginal estrogen needs to be added. And this should be done even if you are giving systemic MHT for VMS. Local vaginal estrogen is the best treatment for vaginal atrophy, and it gives long-term, dividends for treating now. Okay, the net effect, oral plus progesterone on serum HDL cholesterol is still beneficial. So remember that in women with dyslipidemia, if they are well controlled with diabetes, MHT will be able to boost their serum HDL levels, which is actually very good for them. What about the choice of progesterone for women with obesity and MS? I think Dr. Hepzibah also said, I just want to highlight the PEPI trial, where it was an RCT of 875 women, okay? And in them, one arm was actually, it is a little older study, so they were still using conjugated estrogen with medroxyprogesterone, which we don't use nowadays, or with cyclical, and the other one, they had cyclic conjugated estrogen with micronized progesterone. And the trial revealed that micronized progesterone is lipid-friendly option. Okay, so that is how it goes in women with obesity and diabetes and metabolic syndrome. Micronized progesterone may well be the progesterone of choice. If that is giving side effects or is not available as a formulation, then even dydrogesterone and even levonorgestrel can be other options. In well-selected women, MHD has the potential to improve weight loss, which is desirable in these women, metabolic syndrome parameters, and it will reduce all-cause mortality. This is what we are looking at. And this is a prospective study of 650 women followed up for 15 years. And they found that estrogen therapy has a neutral or favorable effect on body fat distribution, favoring the pear-shaped body rather than the apple-shaped. Okay. So symptoms will be indications for us, and individualized approach will be necessary. One word about MHD and dyslipidemia. I already said that total cholesterol levels and LDL, MHD will lower total cholesterol and LDL and have desirable effect of an increase in HDL. So this may be, this is true, but it has to be combined with statins. Adequate dose of statins as prescribed, because the MHD is going to slightly increase the triglycerides, all right, especially the estrogen. This effect, but this can be avoided if you give the transdermal route, yes. This effect favorably compares with statins. Statins do not show any benefit on HDL. So you give a combo therapy, MHD and statins for best outcome. Obesity with coronary heart disease, MS, statins first choice, MST no role in secondary prevention, established. Matter of suitable progesterone is PEPI trial, which I have spoken. MHD and DM, okay, combined HT appears to reduce the risk of type 2 diabetes actually. So it can be used as prevention in women with metabolic syndrome if they are not already diabetic, but not as primary prevention, just to understand that this kind of therapy, MHD, for symptomatic women, the studies have shown that fewer cases of diabetes will be there in those who have taken MHD. So it can have some prevention for diabetes also. But in symptomatic women only it must be used. It cannot be used as a primary method of diabetes prevention. Established CHD, all right. So I have already said that we need to have statins as the first line. And so if women with established cardiovascular disease, coronary heart disease, if they develop symptoms, then we have to resort to cognitive behavioral therapy, SSRI and SNRI, gabapentin, oxybutynin, fezolinetant. These are the drugs which can be used. And again, as I am saying, maybe we will have to resort to an endocrinologist to help us out with this kind of. But once started, we can very well monitor and we can become adept in prescription of these drugs. Weight loss is mandatory for them. There cannot be any forward progress without weight loss. And there is some work on stellate ganglion block. We will not touch upon that. About sexual dysfunction in them is more prevalent in them, with the exception of those who have had the PCOS phenotype with hyperandrogenism, okay? But then they do require treatment for sexual dysfunction and for GUSM, and that can be managed very well with local estrogen, and sometimes tibolone also is a very good drug for them. Now, let me just finish with saying a little bit about the prescription itself. In well-controlled DM, stable lipid levels, decreasing weight trends. So you please give little bit of time to see that the LSM is in place and weight is going on decreasing. You can prescribe 1 milligram estradiol plus 5 milligram dydrogesterone continuous combined, or CE plus dydrogesterone, or CE plus 200 micronized progesterone. Transdermal estrogen has got a good role, and LNG IUS or micronized progesterone is the progesterone therapy. That is the reason if women come with post-hysterectomy status in this, transdermal estrogen is very good. The only thing which is playing against transdermal estrogen today is the cost. Then the reason why this is the safest, as Hepzibah has already told, that when you take oral estrogen, when women take oral estrogen, the estrogen in the portal vein is going to increase the procoagulants from the liver and the cholesterols from the liver. Of course, it also increases HDL from the liver, but it also increases triglyceride level. Okay, so this is what is going to be different in transdermal, because it will have less of an effect on triglyceride and HDL-C. Okay. So Lenzetto spray is giving 1.53 milligram per day, and you can add micronized progesterone or dydrogesterone. I think all of us are very good in prescription of micronized progesterone and dydrogesterone. We do it a lot for pregnancy situations, so it's not difficult. The only thing we need to pick up is the Lenzetto spray. Vaginal estrogen therapy, if indicated, should be liberally prescribed. That is one which you should liberally prescribe and have a close supervision. Up till 1 to 2 years safety data are there. Recent studies are saying even longer safety data are there. No need to add progesterone if you're not planning to, if there is no other need to add progesterone. In general, this is dose equivalence. 0.625 mg of conjugated estrogen which you are using is equivalent to 1 milligram of micronized, 0.05 milligram of transdermal, or 5 microgram ethinyl estradiol. There is one concept which I wanted to share: ultra low dose estrogen. So if this becomes available, it will be ideal for our women with obesity, metabolic syndrome. It is 0.014 milligram per day. Okay, so this is half of what we are giving now, one third, 1/4 of what we are giving now. And oral micronized 17 oral 17 beta estradiol. Even the compositions available today on estradiol are micronized. So please remember, oral micronized estradiol is better than just estradiol. So some of the older molecules of estradiol are not micronized. So please look out for it. So oral micronized in very small doses like 0.25 milligram per day instead of 1 milligram per day. So that also will be enough to reduce bone loss, and it will be enough to treat the hot flashes. At the same time, it will go with the principles of minimal estrogen for these high-risk women. Of course, the role of surgery is a different ball game. So if there are tumors, etc., androgen secreting tumors, and women come with metabolic syndrome, hyperandrogenism, then such treatment has to be given, and the bariatric surgery in indicated cases. So with that, I will stop sharing. If there are any questions, we can do so. I made an attempt to bring in MHD. Thank you very much. Thank you.
Doctor,
Shobha, can I speak? Shobha, can I speak?
Of course.
मैडम को बोलने दीजिए पहले, फिर मैं बोल लूँ.
just a thing, why not to give Tibolon?
Yes, ma'am. I mentioned Tibolon. And Tibolon doesn't have any specific disadvantage here, the metabolically speaking, and it is useful in older women with sexual dysfunction. It is slightly less effective on VMS, yes, but for obese women, slightly more bloating may happen with Tibolon, and there is slight fear about breast cancer. So these are but otherwise Tibolon is a good drug. It is a good drug. It is a good drug.
Thank you.
Yes, ma'am.
So,
Ragini?
Shobha, very beautifully elaborated prescription you have given. I'm just going to sum up. Yeah, so there are 10 points, like a Bible Testament, 10 points. Number one, counseling and education and awareness should be there. As a gynecologist, when we writing a prescription for these women, we have to spend more time than writing only the prescription. That is very, very necessary. Number two, all the time, every gynecologist cannot have a multidisciplinary approach in a way. Maybe in a smaller place, they don't have a registered dietitian, a good physiotherapist, psychologist, or even an endocrinologist. So they have to be a basic awareness of everything, and they have to give the counseling session for everything. And as you told, it is very, very clearly you have told everything, starting from the diet, exercise, positive mental health, along with the what we give in all last prescription, calcium and blah blah blah. Coming to VMS, Every gynecologist should forget the equine estrogen today. Forget MPA. When I see a prescription where MPA is written, it really painful. We should only remember the dydrogesterone and micronized progesterone. Maybe in the future something else
It
will
makes
come.
its way here, Ragini, because there are many years all
And
studies were
LNG,
done
no
with
doubt.
this. Yeah, all the trials, all the studies were done
So
with the
MPA
So
is
if you
very much
mention the
clear
studies,
that
then
it
it
increases.
crops up. Yeah, correct.
And yes, transdermal estrogen is the best for these comorbid women. All the time, again, we should not talk about the cost, because when we weigh the benefit versus the its effect, it will
Sure.
really good for them. Maybe it is little high. We are nobody to judge whether they can afford it or not. So we have to talk to them, and transdermal with your this low dose is nothing, and it will get benefit them at all. So this is my sum up for whole of you what you have talked. So
Thank
please
you so
carry on.
much, Ragini.
Thank-
I think without further delay, we will bring in the physiotherapist, Dr. Arati Prasad. And Arati, you can share your screen because there's so less time. She's a brilliant physiotherapist from Bangalore, and we have introduced her in the last session. So I think even she will consider it a waste of time if we put a slide and all. So Arati, you can please start. Can you please pin Dr. Arati Prasad's screen, please? Can you help us?
Yeah.
Paresh ji?
Thank you so much for calling me over time and again. I'm really happy.
Yeah,
More importantly, today we were talking a lot about menopause. We were talking a lot about metabolic conditions, diabetic conditions, and things like that. And
can you increase your volume, Arti?
Can you hear me now?
Yeah, okay, but can be a little better. Yeah,
I'm on maximum.
Dr. Arati. Yeah, okay. Dr. Arati Prasad
Listen, Shobha, don't introduce me anymore.
Musculoskeletal physiotherapist for 40 years. Okay. Yes, please. Okay. Stop sharing, Paresh ji, and please pin. You will pin the screen, no, for her, so that she can show the exercises. What you did last time.
Okay, done. First, just let me tell you, when there are a lot of patients who come to us complaining of shoulder pain, and when they come to us or they complain of pain in the night during the sleeping on the shoulder, the first question that we ask as physiotherapists is whether they are having diabetes. This is one of the ways that there are so many times the patient turns around and tells us that they have not checked their blood sugars. But what we have seen is having a frozen shoulder is one of the first symptoms that they have, by which the diagnosis of diabetes can be clinched. Now, the problem with a frozen shoulder is not the movement. There are a lot of people who come to us saying that their shoulders are restricted, but the problem is it is the pain that is troubling them. It is the pain by which they can't sleep at night on that side. Unconsciously in their sleep they turn to that side and they sleep, and then they get pain, and that keeps them awake during the night. This is the biggest problem that all these people face. So what we as physiotherapists do is, when they come to the department, we give them something called either ICT, ultrasound. We also have latest techniques like laser, needling, and I use something that is called as matrix rhythm therapy, which improves the basic cell biology, and that improves the pain and the shoulder. We also improve the drainage of the lymphatics. Now, as the previous two speakers said, exercise becomes the mainstay for all this. So I'm going to have a small segment of showing exercises for the midriff. Now I'm just going to jump ahead and go straight away. Start with exercising for the shoulder. I will show you some stretches which you can teach your patients and ask them to do it. Is that okay, Dr. Shobha?
Yeah, perfect, perfect, perfect.
Okay. So here we go. Yeah, so I'll just adjust the screen slightly. Now, can you see me clearly now?
Yes, we can see you.
Yeah. So what happens is when a patient comes to us with a frozen shoulder, they invariably lift the shoulder like this. It goes up like that. It goes up like this. And their major complaint is they are not able to put on their bra hook. That is their major complaint that they have. And they are not able to clean themselves when they go to the restroom. So that means their internal rotation is restricted and they are also unable to comb their hair and plait their hair. Everybody doesn't cut their hair short like me. So what we teach them basically is some home remedy, some home exercises which they can do. So the first exercise, the first thing we teach them is a stretch of the lower capsule of the shoulder. So we teach them a stretch like this. We tell them to stretch it out, hold it for 10 counts. Before they start any of the stretches, let them start doing say a hot water bag, keep it for 10 minutes, and then start doing the stretches. So the first thing that we ask them to do is a stretch like this. This is called a inferior capsule stretch. So you stretch and you hold it for some time. So you have stretched that part and then you ask them to pull it behind. So they stretch the anterior capsule. So you stretch, hold it for some time, or they hold on to a window rung and tell them to hold it for some time and pull it. So as soon as they finish that, then we ask them to do the movements. We ask them to take it up as high as possible. And if possible, try to pull it with the other hand. So tell them to pull and hold it there.
Aarti, that part was not seen, Aarti. Maybe you can sit and show.
So I just want them to stretch. Stretch with both the hands.
On the sofa, if you sit, it will be seen. हाँ, सोफा पे बैठ के दिखा दीजिए, please. Thank you. Thank you.
So we stretch, take it out, and we ask them to stretch so that their flexion of the arm improves. This is one exercise that we teach them. The other one is do abduction. Most of the patients will be doing like this. So we have to tell them not to do any bodily movements and tell them to sit straight and then do the exercises. We ask them to take it up, just hold it down and take it up. Now, if I want the shoulders and the scapula to be stabilized, what I do is I ask them to take it behind. Just tell them to move it behind and then take it up, so that the scapula doesn't go up like this. So we ask them to do this exercise so that the rhomboids and the middle fibers of the trapezius act.
Hello.
Can you hear me?
Yeah, we can hear you.
Okay. So this goes to the side. So you do your abduction. That is important. And for the internal rotation, we pull it. We pull it up. Pull it up. That is for internal rotation. And then we do the external rotation. We stretch it out. And this is all the home exercises. But when they come to my department, then we do a lot of stretches for them with the help of different gadgets that we have and also with our hands. So this is home exercises which you can tell your patients across the table. You can just tell them and stretch it out. Stretch. So these are some of the exercises that they can do at home. Now, I have something that's called as you can call it an elastic resistance band, which I use a lot in my department. So we can also use this. This is extremely useful to improve your strength. Once we have started getting stability, we go to the next step of improving the strength. So we just lift it up. So you can see the resistance that the band offers to my shoulders. So I do the same movement. I keep it there, hold it, and bring it down. Again, I keep it there, hold it, and bring it down. Now take it up in front and down. Now take it up in front and bring it. Then you want to improve the rotations. Always remember, whenever you're doing any exercises in a standing position, you need to pull your core in slightly so that your spine remains absolutely straight. That is very important. So, and then you take this and stretch it out and bring it in slowly. Now, when you bring it in slowly, there is going to be an eccentric contraction of the muscle. So that is also going to improve the muscle power. So we do this and bring it back. And then we do this and we bring it back. Now, since we are attempting the shoulder, I'll add on a few exercises and you can do this. Bring it up. You can stretch it and bring it back. Again, stretch it and bring it back. Then I'll show you some exercises for triceps and biceps. So it's going to be up, up, and you can do a few repetitions and lean forward slightly and do for the triceps. Stretch for the triceps. So you can use the band the way you want. You can play with it and you can form your own exercises, but it helps to improve your muscle power. Now, the previous two speakers talked about a lot of changes that can occur, especially in a woman, about the girth that increases the midriff, on the midriff. And that changes the whole metabolic system. So what I'm going to teach you is very simple exercises which you can advise your patients to do it. Now, the one thing I want to add on to whatever the speakers have said before is walking becomes sometimes extremely difficult for all these people because they have pain in their knee joints. My advice to them would be they can go on a static cycle as an aerobic activity, or they can get into a swimming pool and do water aerobics, which is going to be extremely good for your heart and for your walking. And it does not, actually it helps the knee joints a lot. I think that would be really good if they can get into something like that. This is my advice.
Aarti, what is static cycling?
Static cycling is not the normal cycle that you go on the roads because you're scared about losing balance, you're scared about falling.
Gym cycling, ma'am, gym cycling.
Do cycle which you normally get in the gym also, you can just use it. See, the advantage with it is...
But if they are having osteoarthritis, will they be able to do it? I mean, will it not hurt?
No, because you're doing a non-weight bearing exercise for the knee joint. The weight is being borne by your hip joint, your pelvis. Your knee
Okay.
doesn't get affected at all.
Okay, so it doesn't hurt that much. Okay.
It doesn't hurt the knee. If you don't have complete movement, do half movement at least. Because you're not able to walk. The walking becomes very painful. So that is that.
That is always there. That is always there.
That's always there.
Another thing I wanted to ask you, some of these, because some people can't bear weight for long, so because of the knee joint pain. So can they lie down and do any of the exercises, and will it help them? Or sit and do?
No, you want to lie down for the shoulder or for the midriff?
Midriff.
For
shoulder, I think they can do. No, this sit and do, as you showed also. Yeah, I mean you sat down for visibility, but they can do some of the exercises while sitting. Midriff, will they be?
Yeah, can I show you some exercises in a lying down position, so that will be really good.
So today's will be challenging. What else did you have, Aarti, today in mind? Because we'll get you in again for those, I think, challenging situations.
No, I wanted to show you only the midriff exercises and the
shoulder. Okay, please show us. Yeah. With that we'll end. Yes.
You want me to show some exercises in standing for midriff? I'll show you.
Standing midriff. Yes, standing midriff. Please.
Next time we can do the floor exercise.
Yeah, we can do the next one.
The first exercise, which is going to be very helpful even for your pelvic floor muscle, is you just have to move your hip up and down. And that's going to be a strong abdominal contraction. So you do this, just keep doing whenever you have the free time, just keep moving. And this is like belly dancing. And belly dancing
the Bollywood step actually.
Actually, it's Shah Rukh Khan step.
Yeah.
Yeah. So this is an extremely good exercise for your abdominal contraction. It's very good. And it's a very good exercise for your pelvic floor also. This anybody can just keep doing once they get the hang of it. And then you can also do this. This is also Bollywood step, Shobha. And then you can do a circumduction.
You recommend keeping the abdominal muscles tight during this time?
Yes. Throughout the day, even when you're working, you're sitting, you're writing a prescription, a small muscle, not tight, just a small contraction of the muscle. And that is slowly, definitely over a period of time, going to make your stomach toned up. More importantly, forget flat.
That's a good message.
So toning up your muscle, more importantly, this can be done. The other simple exercise that you can do is for the obliques. You can just do this. Just do this, and that's going to improve your midriff again. Just do this. That's going to improve your midriff again. You can do this. This is going to be for the obliques that you can do. As simple as this. These are some of these standing exercises which you can improve and do it at any time you want. Just don't do it immediately after a full stomach. That's all. Otherwise, you can just keep doing these simple exercises, which is going to tone up. My most important message today is tone it up by just pulling it slightly in. Just pull it in slightly and leave. Just pull it in and leave. That's all. Okay?
Yes. Very nice. Thank you. Absolutely.
Okay.
Absolutely. Yeah. We can stop sharing. Yes.
Okay.
Thank you, Aarti. You are such a gem and you are so very good in your field. And we are very grateful. IMS is very grateful for your contribution. Can we stop the share, please, Mr. Paresh? Hello? Paresh ji? Thank you very much. To stop, no? Yeah. So thank you, Anil Kaur ji. You liked the program and you stayed till the end. Thank you very much. Any inputs, Anita ji, Ragini ji? Can we wind up? Yeah. Yes.
Yes, it was Shobha. It was very informative talk, and all the speakers have given a very informative messages.
Thank you.
And I'm sure our audience must have enjoyed it. So, like every prescription writing webinar, this was also superb. And a lot of thanks to you for
Thank you for the
managing and
opportunity. Thank you for the opportunity. Yeah. Thank you so much for the chance. Yes. I'm very grateful. Yes. So with that, I think, and with a lot of thanks to the speakers, Dr. Mahesh and Dr. Hepzibah and Dr. Arati Prasad for those excellent demonstrations, and to Madam Anuradha and Asha Madam. And I really am very grateful that they could join today. And thank you, Ragini, for being there always with me. And Anita ji, thanks a lot. I think there are only, some good messages are coming, feedback. Anil ji has been there throughout. So does she want to say anything?
Yeah. Shobha, wonderful program, very informative. I would request Dr. To share his chart of average weight, BMI, abdominal circumference, because there were some new parameters which we don't note down generally. So if you can just share that one chart with us.
I'll do that. I'll do that, and I'll send it to you and to whoever else is interested. Definitely we'll do that. And one thing is that this whole program is recorded, and I think it is getting uploaded to the website, isn't it, Anita ji? Yes, no. So then we will be able to source it from there also if we are not able, but I'm sure Mahesh will send and we will be able to share that. Thank you. Thank you, everyone.
Share your website also after every session. Sometimes we forget to save it.
Correct. Yeah. Thank you very much. Thank you. So with that we end. Till next time. Bye.
Yes. Bye.